And now we're going to move on. We're going to talk about endocrine, starting with diabetes. So the very first thing to understand about diabetes is that it's not a single disease. It's actually a group of diseases. So even though we often just say diabetes, the correct name is diabetes mellitus. So what does that mean?
Sweet urine.
Diabetes means fountain. So lots of urine. And then mellitus means honey. So it's lots of sweet urine. Now, contrary to what that name may imply, we will not be tasting our patient's urine. Do you understand? Now, in the old days, that's actually one of the ways that you would know if your patient had diabetes but we don't do that anymore. So now we have chemicals that do it for us.
Wouldn't you like get on the sidewalk and have ants if the ants went to it?
I guess that would be a way to do it. So in this case, though, we're not doing that. So what characterizes diabetes, the reason there's sugar or glucose in the urine is that there's excess levels in the blood. So we're going to talk about some general characteristics of diabetes, and we're going to talk about the two major forms of diabetes. There are some others, but we're just really going to focus on the main two types. And they are conveniently named type 1 and type 2. So kind of like Dr. Seuss here. Hold on just a moment. It looks like I'm obsessed with colors, but these are not mine.
Really
I'm stealing them. Yeah. All right. So the defining characteristic is elevated glucose in the blood. As far as diagnostic criteria goes, there's several different ways we can diagnose it. So you can do what's called a fasting plasma glucose, FPG. And if that is greater than 100, sorry, if it's less than 100, your patient is normal. If they are between 100 and 125, then they are considered to be pre-diabetes. In the old days, we called this impaired glucose tolerance. Now we call it pre-diabetes. And then if they are above 125, so 126 and above, then your patient is considered to be diabetic. Now, this is for what kind of glucose? Fasting plasma glucose. Now, you can also do what's called a casual or random blood sugar. And if that's above 150, we typically would consider that to be diabetes. Casual or random. Yeah. So that's casual or random. And then we also have what's called postprandial glucose, which means after a meal. And that's going to be calculated typically as 2 hours after beginning a meal.
What is it called?
Postprandial. Yeah, post meaning after and prandial meaning eating. So 2 hours after a meal is considered postprandial. No. The last thing that we have is something called hemoglobin A1C. Now, what's normal adult hemoglobin called? Hemoglobin A. So what is this 1C thing? Well, as it turns out, how long does a red blood cell last?
4 months.
About 4 months. So during those 4 months that it's alive, it's floating around in sugar water, right? So a certain amount of the chemical in it is going to get sticky or glycated or glycosylated. Don't ask me the difference between glycation and glycosylation, who cares? Sugar sticks to it and bonds to it chemically. So you can think of it as it becomes sticky with the sugar. Now, do you think that the amount of hemoglobin that becomes sticky is going to be higher if the blood sugar is higher? Sure, that makes sense, right? The sugarier the blood, the more likely some of that hemoglobin is to become sticky. So the percentage of hemoglobin that has been glycated is called hemoglobin A1C. So normal is less than 5.5. Glycosylated or glycated, either one can work for you. So So glucose, change the glue to a Y,
Yeah, I got it.
and then 8.
But it says that it's
There's
wrong
no C on here.
Of course it does. You do not have Microsoft Word Medical Edition.
Is that a thing?
Yes. I don't think it is. You just have to add it to your dictionary. Okay. So less than 5.5% is going to be considered normal. And then once you go above a certain level, drawing a blank at the moment,
5.6 to 7.
5.6 to what?
7%. It's controlled diabetes.
Well, hold on.
Oh,
Okay.
sorry.
So once you go above 5.5%, we're considered to be pre-diabetic. And then I want to say it's 6.5% is considered diabetes. Yeah. So you've got normal, and then you've got your pre-diabetes, and then your diabetes.
So it's not controlled and uncontrolled? You changed it?
Hold on. Okay, so you don't have diabetes if your hemoglobin has never been above 6.5. Does that make sense? So, okay, don't look at your computer. Look up
I'm
here.
reading my notes.
I know. Hold on. Okay, so let's say you started out in life with a hemoglobin A1C of 5.2%. And then as you develop diabetes, over the years, you slowly go up to 5.6%. Okay, you don't have diabetes yet. What do you have? Pre-diabetes. Now, let's say that eventually, as things go up, you get 6.8%, 7.2%. Now, at 7.2%, are you controlled? No. But let's say with lots of work and drugs, you end up and eventually you get back down to 6.4%. What do you have? Controlled diabetes. Does that make sense?
Yeah.
Yes, I know. So once you've had diabetes, even if your hemoglobin C comes all the way back down to here, we're still going to call it controlled diabetes. But if it never reaches the threshold for diabetes in the first place, you're going to stay in the pre-diabetic category. Does that make sense? Yeah. All right. So the important thing is that hemoglobin A1C provides us with kind of like an average of what your blood sugar has been doing over the last 3 months or so. In the old days, hemoglobin A1C was only used for management of diabetes after you had been diagnosed by fasting plasma glucose. Nowadays, they have like better technology for the hemoglobin A1C, so we can use it for screening as well as for management. So you can use either of them for screening, and then for the management, we typically want to use hemoglobin A1C. Now, every now and then, someone will have normal fasting blood glucose, but their A1C will still be high, and that's typically when we want to check the postprandial glucose. Does that make sense? So generally speaking, what you want to check is fasting plasma glucose and A1C. And then if those two aren't matching up, then you'll look at postprandial as well. All right. But for our purposes at the moment, we're just talking about high blood glucose. Now, some of the cells in your body can take up glucose without any additional help, such as your brain cells. Your brain cells don't need any additional thing in order to be able to absorb glucose. But most of the cells in your body do require something else, and that something else is a hormone that we call insulin. So insulin is produced from the beta cells of your Isles of Langerhans, named after Dr. Langerhans. By the way, you've heard of him before, right? Because he has some skin cells named after him too. What are those? Langerhans cells, which are macrophages in the skin, and sometimes dendritic cells too. You remember that from Pathopharm? Mm-hmm. No, I don't. Never heard of that before. Okay, so the beta cells are in the pancreas. Most of the pancreas is an exocrine organ. What does that mean? It secretes what? Not hormones. other stuff. Yeah. But there's little pockets, islands of cells in the pancreas that are not exocrine, they're endocrine. What does that mean? Now say hormones. They secrete hormones. And the major hormone secreted is insulin. So there are two major reasons why blood sugar would be high. And one of those is if we have lower insulin production. So if something is attacking the beta cells and destroying them, they're not going to be able to produce as much insulin as usual. And eventually you get to the point where they can't produce any insulin at all. That particular disease process is called type 1 diabetes. Now, say again? Yeah. Now with type 1 diabetes, what caused it in the first place? What do we say happens to the insulin production? It goes down. Why does it go down? Because something's attacking the beta cells. What would be attacking the beta cells?
Infection.
Not an infection.
The body?
The body? What's it called when the body attacks itself?
Autoimmune.
It's an autoimmune disorder. Now, similar to the schizophrenia hypothesis, where there's kind of like a fragile or vulnerable brain, vulnerable genetics, we believe that there is a similar pattern with diabetes. So you're not born with diabetes, you're born with a genetics that is susceptible to diabetes. And part of the reason we think that is a lot of times type 1 diabetes onset is after a severe infection. So the patient will get sick, they'll have like a really bad viral infection or some bacterial infection, and then that's when they start to develop diabetes. So type 1 diabetes develops rather slowly at first, and then it accelerates kind of towards the end. A lot of times patients will have initial symptoms that coincide with another illness. So they get sick, and that's where we get diagnosed them with diabetes. Then they get better from the illness, and the diabetes gets better too. Now, imagine for a moment you're a little, oh, by the way, when does type 1 diabetes tend to occur? In young people. So it used to be called juvenile onset because it mostly happened in kids. Now, it can happen in young adults as well, and rarely it can even happen in adults as old as 30s or even early 40s. That's called late onset or latent onset of adult diabetes, but who cares? The important thing is it's not just kids, although the vast majority of them are children. So imagine for a moment you're a 13-year-old kid who got sick and then got in the hospital with diabetes. They said, you have this disease, you're going to have it for the rest of your life. Now, being a kid, what are you going to think? No way! This is not happening to me. What's that called? Denial. Now, you get better, and you go home, and you don't need insulin. You got better. Now what do you think? I'm cured. Stupid doctors and nurses didn't know what they were talking about. I'm special. I'm a miracle. So we call that the honeymoon phase. So when they got sick, their need for insulin rose. Their body couldn't meet the demand. They ended up getting diagnosed. But after they got better, their body was able to meet their insulin needs at least somewhat for a while longer. And then eventually it goes down again to where they really need the insulin. So that phase where they don't need insulin in the middle there, what's it called? The honeymoon phase. And unfortunately, it feeds into the unique psychology of children. Well, and all adults, all humans, I guess. To feel like, no, I'm special, this isn't going to happen to me. Dumb doctors didn't know what they were talking about. So that's kind of type 1 diabetes in a nutshell. What causes it?
Autoimmune disorder.
Autoimmune disorder that destroys what?
The beta cells.
Beta cells where?
In the pancreas.
In the pancreas. So that there's less what? Insulin production. And eventually, how much insulin production is there? 0. So this is a case where, what's the ultimate treatment for type 1 diabetes? If your body is not producing insulin,
Give it insulin.
we need to give insulin. So up until the moment in time where we were able to successfully extract insulin out of animals, if a person was a type 1 diabetic, they were going to die. So anyone you know with type 1 diabetes is a modern medical miracle, because without the ability to first extract it from animals and now to create it with recombinant DNA from bacteria, they can't live. They would die within weeks, if not earlier. So that's type 1 diabetes. Type 2 diabetes is a little bit different. And in type 2 diabetes, the problem isn't that there's not enough insulin, at least at first. The problem is that the cells are not listening to the insulin signal. Now, the reason for that, what's it called when someone doesn't listen to you?
Selective hearing.
Okay, sure. So if I tell you you should study a certain way and you decide you're not going to, what would we say you're doing?
Following the rules.
I'm not your parent. I would say that you are resisting. No, I'm not going to do that. So you're resisting. So when cells don't listen to the insulin signal, we call them insulin resistant. Now we're going to talk a little bit more about what insulin does in just a minute, but insulin is a storage hormone. It tells fat cells and liver cells and muscle cells to take up glucose and triglycerides and store them for later. Now, if those cells are already full, are they going to be able to take up the glucose and take in the triglycerides?
No.
No. So the reason they're resistant most of the time is because they're saying, well, we're already full. We can't do that. Does that make sense? So one of the major driving factors of insulin resistance, guess what it is?
Diet.
Okay, what about your diet?
Too much fatty. Foods, sugars, fat.
It's not about sugar versus fat. It's about too many calories. So another way to say it is that an energy surplus chronically is what ultimately leads to insulin resistance. Now, what happens to people who are in a caloric surplus chronically? They gain weight. Yeah. So one of the major risk factors for getting type 2 diabetes is obesity. So if you think about it that way, that a cell that's full doesn't want to respond to insulin. It's going to be resistant. So when you think about it that way, it makes sense that, well, how does it get full? Well, you're feeding the body more than it can handle. That excess energy's got to go somewhere. And so if you're not burning it off, it needs to be stored. Once the storage cells are full, what do? Well, you can build more storage cells, but that takes time. So in the meantime, you are insulin resistant. Now, that would also imply that the two things you might want to do to solve the insulin resistance problems, what would those be? Okay, eat less. Okay, exercise. Use the muscles. When you use the muscles, the glycogen gets used up, and now the muscle cells are empty and can absorb more glucose. So muscles that have been used are much more receptive to insulin because their glycogen stores have been depleted.
This could be like a sleep question. So then is diet and exercise
The major treatments for diabetes? Yeah. Yep.
people are just lazy, so they don't. They're probably not that much.
Well, let's not say lazy. They're what? Not compliant? I don't even know if I want to use the word compliant.
They just choose not to use that.
Oh, okay. Now, we'll talk about management a little bit later. So we'll get into some of those psychosocial issues later. Yes.
So you said it causes them to use the muscles, which causes the muscles to take up.
Right. So when you use muscles, you use up glycogen storage. So now there's an empty space inside the muscle, metaphorically speaking. So now when insulin comes around, the muscles go, sure, I'll take in that glucose. They don't say, no thanks, I'm already full. Okay. All right, so let's talk about the common things with diabetes. As blood sugar goes up, so as glucose goes up, some things are going to happen. And the first thing that can happen is once the blood sugar goes up above 180, some of the glucose is going to what we call spill into the urine. Now, in your kidneys, you've got these chemicals. Their job is to pull glucose back into the blood. So your body doesn't want to have sugar escape in your urine because your body's designed not to die of starvation. And letting energy just get peed out, well, that's not very efficient for survival. So your body's designed to pull that sugar back in. Does that make sense? Up to how much? Up to 180. But once you go above 180, there's more glucose than those little pathways can handle. So some of that glucose is going to begin to spill into the urine. And that is going to result in something called glycosuria. So glucosuria, just change the U to a Y and you've got glycosuria.
The U, no. Oh.
Yeah, no, you don't change the urea, you change the gluco. So, now, as glucose is in the urine, it's going to increase the osmolality of the urine. What do you know about increased osmolality? What is osmolality a measurement of? The answer is not what? Say again? Okay, what is osmolarity a measurement of? Concentration. So, what is it that drives osmosis? Concentration gradient. So when there's more concentration somewhere, water is going to rush into that area. So glycosuria causes increased concentration of urine. That in turn is going to cause more water to go into the urine, which is going to cause an increase in urine. So what's an increase in urine called? Polyuria. So this increase of urine production because of an increased concentration is called osmotic diuresis. What's the driving factor in osmotic diuresis? An increase in the urine concentration. And in this particular case of diabetes, what is the cause of the increased concentration? Glucose in the urine. And that's going to start to occur at what level? Above 180. Now, at above 180, when you do a urinalysis, you're going to see glucose there. You're not necessarily going to get polyuria at 180. It's probably going to have to be like 300, 400, 500 before you start seeing large amounts of polyuria. Does that make sense? So it's not a yes-no switch. It's a gradual increase. Okay. So the first symptom is polyuria, and it's driven by osmotic diuresis. Now the second one is you're going to have an increase in blood osmolality. I guess that could be first, but who cares? Now, what's osmolality? It's a measurement of concentration. So, do you remember the equation for blood osmolality?
2 times sodium plus UN plus glucose over 18.
It's almost like you can read it. Yeah, so 2 times the sodium plus the BUN plus the glucose divided by 18. Now, when the blood glucose is only 100, what's 100 divided by 18, more or less? It's about 5. When the blood glucose is 400, what's the osmolality of glucose? 400 divided by 18. It's about 20. So it's 4 times higher than usual. So as we get increases in blood osmolality, what's the main driving factor of osmolality most of the time? Now, imagine for a moment that you ate a bunch of sodium. How would you feel?
Bloated, thirsty.
Thirsty. Okay, so when you increase blood osmolality, how does a person feel? Thirsty. Now, does it matter whether you're increasing it with blood sugar or whether you're increasing it with sodium? No. What's the end result? Thirsty. So a person who is thirsty, what do they want to do? They want to drink more water, and that is called polydipsia. Now, a person who drinks more water, what are they more likely to do? They're more likely to go pee. So it's kind of like a mutually reinforcing engine there. The more water you drink, the more you pee. But you're also producing more urine than usual because of osmotic diuresis. So ironically, a person who's in this situation can be becoming dehydrated or hypovolemic even while they're drinking all this excess water. And again, this is not something that happens at relatively low levels of blood glucose, like 150, 180. This is something that's going to happen as they go above 250, 300. Now, the third thing that happens is, and this is much more so in type 1 diabetes than type 2 diabetes, because in type 1 diabetes, there's no insulin unless the patient gets it exogenously. Whereas with type 2 diabetes, there's still some insulin there, it's just not working as well as it should, right? Mm-hmm. So this last one is something that happens when a cell is awash in blood sugar, but it can't get it. So if a muscle cell or a fat cell or a liver cell is like, hey, we really want the sugar, but can't get it, what's it going to start to do? If you were surrounded by food, but you couldn't eat it, how would you feel? Sad and hungry, and eventually it would hurt, right? Yeah, so that's basically what happens to those cells. So your cells begin to send out little signals, hey, give us some energy, buddy, we need some glucose around here. And then that gets translated up in your brain, and your brain says, I'm hungry. And so that is called polyphagia. Now, as a person eats, what does it do to their blood sugar? It increases it, which drives this engine of polyuria. So one of the things that can happen to a person in this phase is that they can lose weight while eating anything they want, because they're literally peeing out the food they eat. I've known of a patient who lost about 100 pounds. Leading up to his diagnosis of diabetes. Now, this is in type 1 diabetes. This is not going to happen in type 2 diabetes. So, what are the 3 classic signs and symptoms of elevated blood sugar? Polyuria, polydipsia, polyphagia. Now, the polyphagia in particular is most likely to occur in what kind of patients? Type 1. Now, all 3 of these are more likely in type 1, but they can still happen in type 2. But that last one particularly, you're not going to see it until you get to type 1. In addition to those 3 classic signs and symptoms, I'm also going to include blurred vision. Patients with high blood sugar levels will often complain that their vision is blurry, and as their blood sugar comes down, they say their vision kind of resolves. Now, if a person is in this polyphagia stage where their cells are starving, they can't get any glucose, eventually what's going to happen? If you can't use the glucose for energy, your body's got to come up with some other form of energy to use, right? Mm-hmm. So it's going to start to use fat as an energy source for things that ordinarily wouldn't be used for. So we're going to take the fat and we're going to turn some of it into ketones. Ketones can be used by tissues in place of glucose. Now, how is this different from ketosis in a ketogenic diet? Okay, so the major difference is in a ketogenic diet, there's still insulin around, and the insulin is still telling glucose to go into cells. There's not a lot of glucose, but there's enough. In the case of this, which is ketoacidosis, there's no insulin, there's not enough insulin around to do its job. So there's blood sugar everywhere, but there's not enough insulin. So patients in this case, we call this ketoacidosis. So they're going to be producing so much ketones that the patient's going to become acidotic, and they're kind of literally starving to death at the same time. Serena?
But don't they have, so they don't have any glucose inside? This is they don't have glucose?
No, a person whose ketogenic diet is eating low amounts of carbohydrate. So they're not going to have a lot of glucose. But they still will have some glucose being pushed into cells because they're eating protein still. Protein can turn into glucose. You can also do gluconeogenesis. So, and then they're still going to eat some tiny amount of glucose, of carbohydrate. So it's not that there's no glucose, there's some. And that is still being pushed into cells by insulin. But in diabetes, what's happening is that there's tons of glucose around, but they don't have the insulin to push it into their cells. So their cells are starving to death. So it's a different disease process. There's ketones in both processes, but they're very, very different. So you can live in ketosis from a ketogenic diet for a long, long time without problems. Well, certain problems anyway. You're not going to die from a ketogenic diet most of the time. Can't say you won't, but you're probably not going to. But in the case of ketoacidosis, the patient will die if it's not corrected. So, what do we remember about acidosis?
Diet, it's not correct.
No, what do we remember about acidosis? That just means like Pathopharm 1. I don't remember. Okay, so in acidosis, what are the two major causes of acidosis? M and R. Respiratory and metabolic. In this case, what would it be? Metabolic. So it's a metabolic acidosis. So what would you expect to be low? Bicarbonate. And then what would you expect the body to do to compensate? Respiratory something, right? So how would you go into respiratory alkalosis to compensate? What would the body be doing? What would the person be doing? Breathing, not less, more. So you want to get rid of as much carbon dioxide as possible. So that's going to manifest as someone muttered it under their breath. Kussmaul breathing. So Kussmaul breathing pattern. So what is a Kussmaul breathing pattern? Really big, deep breaths. So imagine for a moment that you just ran a 600 meter. Now, how many of you have ever run a 600 meter? It's like the most evil race in the whole world. It's like a little bit longer than a sprint, but not long enough that you can like just run. You've got to like sprint-ish the whole thing. It's horrid. How do you feel at the end of it? What do you breathe like? Well, that's kind of Kussmaul breathing. Does that make sense? Okay, so your patient won't be doing Kussmaul breathing in the more severe stages of ketoacidosis. Their breath, they're going to be breathing out acetone, so they call that a fruity breath. Now, many of us think juicy fruit. Like, oh, I like the smell of fruit. No. It's like kind of like a rotten fruit smell. If you've ever been like at a dumpster behind a restaurant, that's more like, yeah, it's not a pleasant fruit smell. So you've got Kussmaul breathing, you've got the fruity smell, you've got low bicarbonate levels. Now, what would you expect potassium to be? You expect it to be high because it's what? It's acidosis. And in acidosis, your body tries to exchange potassium for hydronium ions, hydrogen ions. But there's something else happening here that short circuits that it makes potassium low. What is that? It's actually on the board. It's the polyuria. So the patient is actually peeing out all of their potassium. So even though you would expect it to be high, it will actually be low because of the osmotic diuresis. So what do you think the treatment for ketoacidosis is? Say it again. Yeah. Spit it out. Insulin. Right. What kind of insulin?
Just regular.
Yeah, how would we give it to them? We give it to them IV.
Oh.
Now, at the same time, you might also give bicarb and you might also give potassium. As the blood sugar normalizes and the acidosis resolves, you've got to make sure that you don't over-administer potassium, because then the patient will go into hyperkalemia. So in addition to monitoring blood sugar, what else are you monitoring? Potassium levels and bicarb levels. Yeah. All right. Any questions about ketoacidosis? Now, with type 1 diabetes, the way that most patients are diagnosed is by going into ketoacidosis. So, so what happens is, their immune system is attacking their pancreas and their insulin level production is going down. They get sick and it goes way down. Ketoacidosis, get diagnosed. Then they get better and continue this again, and they don't have problems for a little while longer. And then here they have problems again. So what's this time period in between called? Honeymoon phase. All right. So what's the way that most type 1 diabetic patients get diagnosed with type 1 diabetes? Ketoacidosis. All right. Now, these are all symptoms of acute high blood sugar. What do we mean by acute high blood sugar? The blood sugar goes up and you get symptoms. That's what we mean by acute symptoms. No, I'm not going to give you a specific number. But the higher it goes, the more severe the symptoms. So these are not, you don't have to wait like 20 years to get these symptoms. As blood sugar goes up, they develop. Does that make sense? Okay. The next thing we're going to talk about is long-term complications of high blood sugar. So over time, it's not just hemoglobin A that is being glycated with sugar. It's other tissues in your body as well, including your, primarily being the arteries and capillaries throughout your body. So over time, those capillaries and arteries are being glycated as well, which can lead to inflammation and then loss of function in whatever that tissue is. So there's 3 major complications that are long-term complications of elevated blood sugar. So what's the driving factor behind these complications? Say again? Well, glycation of arteries and capillaries. So there's 3 major classes, and then I'm going to give you a 4th one that's a little bit newer. So the first one is retinopathy. Now, what do you think is happening there? Okay, so your eyes are being damaged. What's that ultimately going to lead to? Blindness. So depending on where you read, either high blood pressure or diabetes is the #1 cause of blindness. So they're probably about even. Now, some patients like to have both at the same time. Their risk is even higher. Now, this is not something that happens overnight. How long does it take to occur? Yeah, 20, 30, 40 years. So it's going to take a long time before it happens. So this can occur even at relatively low blood sugar levels. So if you have blood sugar levels of, say, chronically 150, 180, it might not even be high enough for you to have glycosuria, but you still have this very low level of damage occurring, which can ultimately lead to blindness. The next one is nephropathy. So what's being damaged in a nephropathy? Nephrons, which are inside the kidney. Okay, so it's the functional unit of the kidney. As you damage nephrons, what happens to kidney function? It goes down. Now, what is the ultimate sign of kidney damage? Like, yeah, how do you know a patient's got kidney failure? Yeah. Okay, so elevated creatinine levels and BUN levels. So that would be your ultimate, I think this patient's in liver failure, or sorry, in kidney failure, right? But the earliest signs are actually going to be proteinuria. Now, what's the number one protein in your blood? Albumin. We've talked about how you do your analysis, right? In Pathopharm 1, how do you do your analysis? Okay, well, you pee in a cup. Okay. You give the cup to the tech. What does the tech do? They dip the little dipstick in there, and then they what? You're supposed to wait a certain amount of time, and then you compare the color, right? Yeah, it looks like that. Okay. So, a regular urinalysis is not super sensitive at detecting very small amounts of protein in the urine. So, if you see proteinuria in a urinalysis, that means there's quite a lot of damage. So in diabetic patients, you can actually do a more sensitive test called a microalbuminuria. What's the number one protein in your blood? Albumin. So what's the difference between proteinuria and microalbuminuria? It's more what?
Specific?
No, it's more sensitive. It can detect smaller amounts of protein. Now, the microalbumin test is more expensive. So what do you do first? You do the regular urinalysis. If it's proteinuria, do you need to do microalbumin? No. But if it's normal, could they still have protein in their urine? Yes. And how do you know that? Microalbumin. Now, microalbumin is not something you do in the hospital typically. It's something that's done on a primary care basis. And it's usually only done once a year. All right, last thing we need to talk about as far as the nephropathy goes is to reduce the risk of nephropathy, we're going to want the patient to be on a drug class called ACE inhibitor. Now, we're not going to learn any ACE inhibitor names for now. But for the next test, for test 3, cardiovascular, you will. So, but for right now, all you need to know is ACE inhibitors do what? Reduce the risk of what? Nephropathy. Okay. All right. The last one is neuropathy. So what's being damaged there? Neurons. And this can take one of two forms, what's called either central or peripheral. Peripheral is going to be hands and feet. Which of them is probably going to be more likely? Feet. You've got poorer circulation in your feet to begin with, and so it's more exposure to the glucose and less blood flow in general. Your feet are more susceptible. Over time, this can lead to neuralgias, and it can also lead to numbness. So in severe cases, you'll have patients who have both. So on the one hand, they can't feel normal touch, but on the other hand, you like barely brush their skin, they're like, it hurts. So pretty nasty. It can also cause well, if you've got the decreased sensation over time, you don't feel when you're hurt. So I've had a patient, for example, that he stepped on a tack and he didn't feel it. And 4 days later, he comes into the office saying, "Oh, so what's going on today?" He's like, "Well, my foot is bleeding." "Well, how do you know your foot is bleeding?" "Well, my wife said I was bleeding on her carpet in the bathroom." So, and it turns out by that point he's got gangrene in his foot because it's infected and nasty. So because of that, there are increased risk for infections and then increased risks for amputations. They're also at risk for something called Charcot joint. Now, how many of you are familiar with Hansen's disease? Anyone know what that is? You probably know it by a different name, leprosy. So what happens in leprosy?
You start losing your...
You become deformed over time because you start losing extremities and stuff. Why do you lose extremities and stuff? What is it the person has in leprosy? What's the defining characteristic? Say again? The why. They can't feel pain. Now, if you can't feel pain, you don't know when you've been injured, and you don't know when you're inflamed because you can't feel the tenderness. So over time, they aren't getting appropriate help because they don't even know there was a problem to begin with. And so over time, they get more and more tissue destruction until eventually they're deformed. And that same process can occur in the feet of patients with diabetes, and that's known as Charcot joint. The number one, let me just, as long as we're here, let's also just say, so retinopathy, nephropathy, neuropathy. The other one is just damage of small capillaries. And this can lead to decreased wound healing. So when you combine the peripheral neuropathy with decreased wound healing, you get the number one cause of amputations in the United States is diabetes. Now, and peripheral diabetes tends to be from the extremities upwards. So it starts the extremities and then works its way up. So sometimes you'll hear them talk about stockings and gloves. So like they have neuropathy like from here down and then like from here down. The central neuropathy is neuropathy of larger nerves, and that can sometimes be your like your vagus nerve, for example, which in turn is what causes peristalsis. So a patient who's got neuropathy of their vagus nerve might end up having elevated heart rate because they can't control their heart as well, and they could also have constipation and gastroparesis because they don't have adequate peristalsis. So they eat something and the food just sits in their stomach. Now they've got a food full of stomach for several hours. What's more likely to happen? Indigestion and GERD, acid reflux. Okay. And then it's just sitting in their digestive tract, not really moving along very quickly, so they're more likely to have constipation. So that would be central neuropathy. All right, now as far as the small capillaries go, there's one last one we need to mention, and that is erectile dysfunction. Erectile dysfunction and diabetes are kind of like love and marriage. You can't have one without the other. Good old Sinatra. All right, any questions about these complications?
For the damage of the small capillaries, is that part of your peripheral, or is that just like a big, one of like the major?
It's still one of, it's a major one.
Okay.
Yeah.
Thank you.
Yeah, it interacts with the peripheral to increase the risk of amputations, but it's separate.
Okay. Thank you.
Okay.
And
All right.
erectile dysfunction is a subsection of small capillaries.
Yeah, and rather than capillaries, I should say small arteries or arterioles. Okay. So it's not the capillaries themselves that are the problem, but the arterioles leading up to those capillaries. As they get damaged, it decreases blood flow, leading to erectile dysfunction and poor wound healing. Now, all of these, so 1, 2, 3, 4, so retinopathy, nephropathy, neuropathy, and small arteries. All 4 of those are considered microvascular. How long does it take for those to occur? Long time. Now, who's more likely to get them, a type 1 or a type 2 diabetic? Type 1, why?
Because they got it when they're younger.
Well, first of all, they typically get it when they're younger. So if a person gets it when they're 12, by the time they're 42, they've had diabetes for 30 years. On the other hand, if a person who has type 2 diabetes typically is older, so let's say they get it when they're 45, what's 30 years for that person? 75. Now, the other thing is that because a person who has type 2 diabetes has kind of like a very slow slide into it typically, they don't go from like blood sugar of 70 to blood sugar of 400 overnight. It's usually several years developing. They just have a slower development into the diabetes. A person who's got type 1 diabetes, because they don't have any of their own insulin, it's just a little bit harder to control blood sugar in general. Now, the advent of modern insulin pumps and then also continuous blood glucose monitoring helps, because you can give real-time feedback and much tighter glucose control than we could with just giving shots of insulin a couple times a day. So it's better now than it has been at any time before, but type 1 diabetics typically still have an increased risk of these over type 2 diabetics at an earlier age. Any questions about microvascular complications? When do we get them? Later on. Can they occur if a patient doesn't have glucose in their urine? Yes. So sometimes older patients will think, well, as long as there's no glucose in my urine, I'm okay. But you can still be developing these even at relatively low blood sugar levels. So like 150, 140, you can still develop these. Now, the other type of vascular complication is called macrovascular. So these are all micro. And now we've got macro. And the macrovascular complications are coronary artery disease, stroke, and peripheral arterial disease. So with coronary artery disease, what's the number one thing that happens? It is multifactorial. But what is coronary artery disease? The disease of the coronary arteries. What happens if you have a blockage of your coronary artery? You could die. And what would that be called? Dying from what? A myocardial infarction, which is a fancy smancy way of saying a heart attack. So coronary artery disease, heart attacks. Cerebrovascular disease, strokes. And then peripheral arterial disease, part of that goes back to this wound healing issue. And then part of it is also intermittent claudication. So there's not enough blood flow to your muscles when you use your legs, so you end up getting leg cramps. What's that called? Intermittent claudication. Now, I once heard someone say that macrovascular complications kill you, strokes and heart attacks, whereas the microvascular ones make you wish you were dead. That's what he said. But anyway, now for type 1 diabetics, microvascular were more common. For type 2, the macrovascular are more common. I guess I should say it the other way around. For microvascular complications, they occur at a higher rate in type 1 diabetes. For the macrovascular, they occur at a higher rate in type 2 diabetes. There's something about insulin resistance itself that increases the risk of stroke and heart attack, even if a person has normal blood sugar. And the risk of the risk of heart attack and strokes is elevated even in pre-diabetes. Does that make sense? All right. We are almost done in terms of time. Trying to think if we should talk anymore. No, please don't do it. Okay, so you've got the acute symptoms, the 3 polys, and you've got the long-term complications over years upon years, the macrovascular and the microvascular versions. We will drop off here, and next time we'll pick up with a little bit more detail about insulin resistance, and we'll also talk about all of the treatments. So learn your insulins, and I realized that we did not have a drug quiz for neuro.
We weren't gonna do that.
Oh,
If we wanted to, we can, but no.
but I thought everyone wanted to.
No.
Oh, you don't want quizzes. All right, fine, no quizzes for you.
I mean, if it's extra credit.
But, yeah, wink, wink, nudge, nudge.
Maybe I'll just ask each of you a drug question in class.
And then we get extra credit.
Thank you. And then if we get it, we can get it.
All right.
Thank you. Consider them.
All right, let's talk diabetes. So we talked about generalities of diabetes last time. So we talked about what is diabetes, and it's a group of diseases. It's not one single disease. And the ultimate result is elevated blood sugar levels. So those blood sugar levels can cause a number of acute symptoms. So we looked over those acute signs and symptoms. And then from there, we talked about long-term complications, and we divided those into micro and macrovascular. So remember, the microvascular ones were your apathies, retinopathy, nephropathy, and neuropathy. And then we also said erectile dysfunction. And then you can also say, to a lesser degree, decreased wound healing. And then the macrovascular complications were heart attacks, coronary artery disease, cerebrovascular disease, strokes, and then peripheral arterial disease, which can be manifested partially by your poor wound healing, but more importantly by intermittent claudication. So that was all last time. This time what we're going to do is we're going to talk about how we treat diabetes. And the way that we treat it is going to partially depend on what kind it is. So we're going to go in a little bit more detail about the different types. So the very first type we mentioned is type 1 diabetes. Used to be called juvenile onset because most of the people who got it were younger. We no longer call it that because you can still get it up into your 30s and even some people into their 40s. Question?
Yeah, can I go back a little bit?
Okay, go back.
How is osmotic diuresis related to polyuria?
Okay, so the question was, how is osmotic diuresis related to polyuria? And the answer is that osmotic diuresis causes polyuria.
Okay.
Glad I could answer that question. So, back to our story. So, type 1 diabetes is usually in younger folks. We talked about last time the vulnerable theory. So, you have a genetics that are vulnerable to developing type 1 diabetes. And then there's some sort of precipitating event, oftentimes a severe viral infection that precipitates the diabetes. And that typically occurs in late childhood, early teen years, but can also happen in young adulthood as well. Now, one of the ways that we can diagnose whether a patient has type 1 diabetes versus type 2 diabetes is by looking at C-peptide. So if you remember, the shape of proinsulin looks something kind of like that, right? So then we're going to cleave that protein there and there, leaving insulin and this peptide fragment. If you turn this peptide fragment this way, it looks like a C-peptide. So if the person is producing their own insulin, they're going to be producing C-peptide. If the only insulin that they're getting is the insulin you're injecting into them, then there will be no C-peptide. So, because patients who have diabetes need insulin a lot of times. So if you're giving them insulin, it's like, well, how do I know if their body's producing it? And the answer is C-peptide. So if you ever see that ordered, what are they trying to figure out? If the patient's got type 1 or type 2. So type 1 diabetes, we said, was an autoimmune disorder where your body is attacking which kind of cells? The beta cells of the pancreas. And so over time, insulin is going to go down to 0. At that point, or even before that point, if we don't give that patient insulin, they will die within a couple days to weeks. Right? Okay. So that's type 1 diabetes. And then type 2 diabetes is caused by insulin resistance. And so insulin resistance is when the cells that are responsive to insulin ignore the insulin signal that says take in glucose. And so what happens is the glucose levels will go up. So one of the major reasons why cells become insulin resistant is that they're already full of energy. So muscle cells and liver cells, that would be glycogen. In the case of fat cells, that would be triglycerides. So insulin tells your body to do a number of things. It tells muscle cells and liver cells to take in glucose and turn that glucose into glycogen, a storage form of glucose. It tells your liver cells to produce triglycerides and send those triglycerides out into the bloodstream. And then it tells your fat cells, the adipose tissue cells, take up those triglycerides and store them as fat. So insulin is an anabolic hormone. It's telling your body to store energy to create tissue. Sometimes people think that insulin is a bad hormone. Well, you know, if you spike your insulin, that makes you fat. Well, only if you're eating more calories than you're burning. If you're not eating more calories than you're burning, then insulin is not going to make you fat, because it can't. In fact, bodybuilders will sometimes inject insulin into themselves in an effort to build more muscle. You eat food, and then you give yourself an injection of insulin, and your muscles take up more glucose than they would otherwise. And that gives you more ability to perform in the gym. So I'm not suggesting you should do that.
It's not like very dangerous.
Yes, it's extremely dangerous.
Can you die doing that?
Yes, you can.
Perfect.
And bodybuilders have died doing that, but I guess anything to look good. So insulin is not a bad thing. We'll talk more about that later. But so insulin resistance typically occurs because the patient is already in a hypercaloric state. The muscle cells are already full of storage. So they're like, well, no thanks, I don't need this glucose right now. And that's why the blood sugar stays high. Now, if you tell someone something and they don't understand you or can't hear you, what do? You say it again, right? Mm-hmm. But this time, louder. You know, so if someone doesn't understand you, if you say it louder, then they'll understand you, right? Yeah. Oh yeah, that's exactly how it works. Especially if they don't speak the same language you do. No, it's not how it works? Well, that's how we think it works, apparently. So basically, that is what your body responds to when your cells ignore the insulin signal and your blood sugar is still high. The way that your body responds is by producing more insulin. So in type 2 diabetes, we start with insulin resistance. Then the body's response to that is increased insulin levels, hyperinsulinemia. This is partially where insulin gets a bad rap. Well, you see, it's the high insulin that's causing the problems. Because hyperinsulinemia is associated with a number of problems. But that's actually not it at all. The hyperinsulinemia is a response to the insulin resistance, which in turn, most of the time, is being caused by a hypercaloric state.
So why do they produce more because does the body almost process it because they're not responding to it as if it's not there?
Not that it's not there, but just that there's not enough. So your body says, well, if your blood sugar is high, it's because you don't have enough insulin. Let's give you some more. So here's what happens in type 2 diabetes. So for a long time, you only need that much insulin. So guess how much your body produces? That much. But then, because of your hypercaloric nature, how many of you ever seen pictures of your parents as younger people? What do they often look like?
Skinny.
Skinny! And now,
Not so skinny.
not so skinny. Well, as they became not so skinny, especially the degree to which they become not so skinny, their insulin needs to have a tendency to go up. So guess what your insulin production does? It goes up too. There comes a point though where there's a cross and your body can't quite keep up with demand. What happens at this point? What happens right here when you can't keep up? Blood sugar. Blood sugar starts to go up. Okay, so you started getting the disease process here, right? Your insulin needs went up, and your body was able to keep that demand. But with this moment, when you have this cross, that's where you start to develop diabetes. But it doesn't start out as diabetes. What does it start out as? Pre-diabetes. Pre-diabetes is just, your blood sugar is up. It's just not enough for us to call it diabetes yet. But you've had the disease process for a long time. Typically, there'll be about 5 years between 5 years of insulin resistance with no symptoms. Then there'll be about 5 years of pre-diabetes, and then you get to diabetes.
When you're pre-diabetic, do they treat you as pre-diabetic?
Yes and no. So the approach to type 2 diabetes is going to be different than the approach to type 1 diabetes. What does a type 1 diabetic need? No ifs, ands, or buts. Insulin. They need insulin. What does a type 2 diabetic need to do?
Exercise.
They need to take that dotted line and bring it back down. How do you do that?
Diet and exercise.
Okay, diet and exercise. Now when we say diet, what do we primarily mean? What is the number one thing they need?
Less calories.
Fewer calories. Now ideally, we would lower the calories until they do what? Lose weight. And losing weight will help. But even if they don't lose weight, reducing calories is still the number one most important thing. Now, sometimes people are like, I don't get it. So let's think about it for a moment. Let's say that it takes 3,000 calories for you to maintain your current weight. But at this moment in time, you're eating 4,000 calories. What does that mean? This is per day, by the way. What does that mean? What's going to happen in your body?
Gain weight.
You've got about 1,000 calorie surplus every day, which is going to be used to help you grow outward. Outward. Okay. Males, females, mostly, on average, not always. But there's about 1,000 calorie surplus each day. Now, what would the person ideally do with their caloric intake?
Lower it.
Bring it to where?
3,000.
3,000, and that way they would maintain their even Steven, right?
Yeah.
No weight gain, no weight loss. Would that be ideal?
Yes, but not for diabetic. Yes.
No.
No.
We said weight loss was a good thing, right?
Oh, okay then.
So where would they need to lower it to lose weight?
2,000.
Okay, well you could, but you don't have to go that extreme. So let's just say that they lowered it to 2,800. Would they start to lose weight?
Yeah.
Yes. It would be slow, but they would lose weight. So ideally, they would go below their current maintenance calories. But even if they just went to 3,100 and they're still gaining weight, but slower than before, that's still better. Does that make sense? So if they lower their calories, even if they don't lower it to the point where they begin to lose weight, they're still going to be better off than if they stay up where they were before. So reducing calories is the number one most important intervention for that type 2 diabetic. Now, remember we said that the vast majority of diabetic patients are overweight or obese. There are a small group of type 2 diabetics who are not overweight, who are insulin resistant even at normal weight levels, but that's unusual. So there's a number of reasons why it could be outside the scope of our particular course. But the vast majority of type 2 diabetics, their insulin resistance is related to being overweight, and dealing with overweightness is going to help their insulin resistance. And in a lot of cases can cure them in the sense that they no longer are at risk for diabetes now or in the future as long as they maintain that lifestyle.
Is it true that gestational diabetes can be like a sign that you might be
We will talk about gestational in a few minutes. All right. So the first intervention is decrease calories. The second intervention is exercise. Now, what does exercise do?
Gets rid of the
uses your muscles.
It uses energy, and it uses the energy where in particular? In the muscles. So by draining the muscles of glycogen, or at least some of the glycogen, it makes them much more responsive to the next insulin signal. At the same time, exercise also mobilizes fatty acids, which are going to be in your bloodstream and be used for energy during your exercise. So when you combine a caloric deficit with exercise, what do you get?
Lots of weight loss.
Well, you can get lots of weight loss, but more importantly, what do you get? You get much better insulin resistance.
Wait.
An improvement in insulin resistance. You get a much better improvement in insulin resistance. Now, if you combine those two things along with weight loss, well, it's even better. Unless you're one of those normal weight insulin resistant people, in which case it won't matter as much. It will help, but it won't matter as much. Whatever I was going to say now. It's gone. So sad. No. All right. So let's talk about gestational diabetes just for a second. Oh, I remembered it now, but it's okay. So gestational diabetes. Gestational diabetes is elevated blood sugar that occurs during pregnancy. If the patient has it and it goes away and doesn't come back after delivery, then it stays gestational diabetes. If the patient's blood sugar stays high after delivery, then we call it type 2. So to answer your question, the answer is yes. Gestational diabetes is a risk factor for type 2 diabetes. And you might want to say it another way. It's a precursor, potentially.
So could your habits, like before pregnancy?
You could be predisposed to it. The pregnancy allows it to come out. And then...
Does, like, how, I don't know if it's like outside, but like why does like getting pregnant?
There's a number of reasons, and we're not going to talk about them in this course. So sad.
Lots of questions.
I know. So many questions. So many questions. Now, we used to call type 2 diabetes adult onset diabetes, and it's most likely to occur in middle-aged or late adulthood. And the reason for that, like you all said, what do your parents look like when you see pictures of them when they're younger? Skinny. Oh my goodness, I can't believe how skinny they were. You know what that means?
We ruined their lives.
No. What might you look like when you're their age? Yeah, there's an old saying among certain people. When you're dating that cute young thing, before you marry them, look at their mother.
Dang.
Because they might not always be that cute young thing. But it goes both ways. Not just for girls, it goes for guys too. So anyway, most of us have to take very deliberate measures not to gain weight as we get older. In the United States, especially, we have so much food available, and the food tastes so wonderful nowadays. You know, it's like they just know how to make food taste compelling. So it's easy to overeat. And the older you get, the less opportunity you have typically to exercise. I mean, think of from you to your high school self. How many of you were much more active in high school than you are now? How many of you sometimes like, man, I wish I could go back to that. But there's no way because you just don't have enough time or opportunity. Well, imagine when you've got 2 kids and a full-time job. They're going to have even less time to be active than you are now. So without making deliberate choices, you're going to end up looking like kind of like I did about 3 years ago.
You?
Yeah. I was 215 pounds. I looked like Santa Claus. Like my face was all pudgy, kind of like Fat Thor. Yeah, that was me. I'm Fat Thor. Yeah. I do. I'm not sure we're going to put it in the video, but yeah, I do have photos. You can see some of them on my website. Maybe I'll let you see them later. So I was about 215 pounds, and it came to a head when I graduated from high school. I was 145 pounds. Skinny little dude. Same height as I am now, skinny little dude. So then I went to the Air Force Academy and we did basic training, and they try and starve you in the military in basic training. So I actually lost 11 pounds. So I was this height and I was 135 pounds. No, 134. I looked like a skeleton. So then after that, yes. So then after that, life happens and stuff happens, and eventually I graduated from college. I was 172 pounds. Then I went and worked at the Breakers for 6 months while I was waiting to go to grad school. And I was a lifeguard and a beach attendant. So if you ever worked as a lifeguard or beach attendant, you burned a lot of calories. So I went down to about 165 when I stopped working there. But then I went up to grad school. And guess what you do in grad school? You get fat. So I had to take some measures and started doing karate and went back down to, I was 190 almost when I got married. Got back down to 185. And then you go on a honeymoon. And then you eat. So anyway, I stayed around 190.
Yeah, it's like that relationship.
Yeah. Yeah. What was the first thing you do when you start dating regularly? You get fat.
Yeah.
So I stayed 190 more or less until the first kid was born. Yeah, I gained the baby weight. So I started gaining a bit of weight. But by the time the kid is like four months old, we got it figured out. You can still work out on a regular basis. It's okay. Except that something else happened. My knees started hurting. Yeah, so for years upon years, I was like, you know what? I can eat whatever I want. I just have to exercise. But as it turns out, as you get older, you can't do enough exercise anymore because your knees won't let you. So, I'd done Slim and 6 and Power 90, which is the precursor to P90X. Then I did P90X, and for like 4 months, you can't sit down. Now you drop something on the floor and you're like, yeah, because everything is sore all the time because of muscle confusion, which actually doesn't do anything, by the way. And then I'd done Rush Fit, which was like, similar idea, but from from Ultimate Fighting Challenge, the UFC guy, George St. Pierre, Rush, forget it. Anyway, I guess you guys don't do UFC. So, did all that, tried Insanity. Insanity is insane, it's stupid, you shouldn't do it. But I love to feel like I've done so much work. Yeah, but it's fantasy. You feel good about it, but it hasn't actually done anything helpful for you. So anyway, couldn't exercise enough. Then the second kid comes along. Now, second kid comes along. Guess what happens? 2 years later, I realized I'd only worked out 3 times.
What?
in 2 years. That was rough. And got up to 215 pounds. So you know what the ultimate secret was for me?
Eating.
Oh, yes. It's a little app called MyFitnessPal. There's others. You can use My Macros, My Net Diary, whatever you like. But the key is, my rules were, I wasn't allowed to eat it until I logged it first. And then I was supposed to eat a certain amount of protein per day, and I wasn't supposed to go over a certain number of calories per day. So basically, eating 1,950 calories, more or less, for 6 months, I went from 215 all the way on down to about 185. No, 180. Then to get from 180 down to 166, I lowered my calories to about 1,750 calories. I know, it's kind of low, isn't it?
Yeah.
Yeah. But it was for a good cause, because I was supposed to go on a cruise where I could eat whatever I wanted. But anyway, so that was the secret. The other thing I did different,
Exercise?
I lifted weights. I'd never lifted weights before. I mean, not real. You know, you go in the gym, you're like, oh, look at this, I'm lifting weights. So I actually did a workout program. Guess how much time I spent in the gym each week? It's about an hour and 45 minutes. So it's about 45 minutes 3 times a week. That's all you need. And then on the other days, I'd walk for about an hour. 3 laps around the neighborhood. That was it.
What's your calorie intake now after your cruise?
Hold on.
Oh, sorry.
Yeah. This was 3 years ago.
Don't jump ahead.
This is all 3 years ago.
Oh, I thought it was
So,
3 years ago. Okay.
the very thing, for years I told myself I can eat whatever I want as long as I exercised. But then eventually I knew that wasn't true because I couldn't exercise enough. But I wasn't ready to give up eating whatever I wanted because my identity was tied into I can eat whatever I want. I was 14 years old. I don't know what you know about 14-year-old boys, but we eat everything. You could probably eat 5,000 calories a day, eat an entire package of cookies, the entire box of cereal, and we don't gain any weight at all.
So jealous.
I know, right? But the problem is you take that identity into your 20s and guess what happens? You get fat. So the key was you can't eat as much and you have to do a little bit of exercise. Now, I was killing myself with things like P90X and Insanity and wasn't working. No. I tried running. Did that work? No, it hurts your knees even more. So guess what worked? Walking and lifting weights 3 times a week for less than an hour each time. You know what I said to myself after I had lost 45 pounds? 5 pounds to go. I said, I wish I'd known it was this easy when I was in my 20s. I could have been looking that good all along. Man. Okay, so. Because this is what you have to tell your patients. You need to tell your patients, you need to change how you think about yourself. You don't have to do a lot of work, but you do have to do some work. And it's less than you think. It's less than you think if you do it well. You don't have to kill yourself with insanity. You don't ever have to sweat if you don't want to. The only reason I sweat now is because now my goal is not lose weight, but get stronger. So now I sweat because I want to get stronger. But when it was just, I just want to look a little bit better and lose some weight, never actually had to sweat if you didn't want to, assuming your gym is air conditioned. If it's not air conditioned in Florida, you're going to sweat. So.
Did you do like full body weight workouts or focus on?
Okay, both. Now I'm doing more full body workouts because I care more about that. But at the time I was doing, it was 1 day of legs and then 2 days of upper body because the whole goal is to look big. Yeah, but hey, whatever. The important thing is that you're using weights that are challenging. So here's how girls like to use weights. I'm going to get the 2-pound weights and I'm going to work on stabilization. And that's lovely.
Yeah, that's what I do.
You can do that at the end of your actual workout. What you need to do is lift challenging weights. So the first time you go in, you choose weight that's not too hard, and you do a set of, say, 8. You're like, that was easy. So now what you do? You go up and wait. And you do another, wait 2 minutes, do another set of 8. And when you're like, that was still pretty easy. Now what do you do? Go up another. And so you go up until you find a weight that when you get to 8, you're like, that was kind of rough. I mean, I did all 8 and I could probably do more, but that was a little challenging. Now that's your weight. Do that again 2 more times. Does that make sense? So you want weights that are challenging. And the rep range that you choose, if you want more strength, probably more in the 4 to 6 reps. If you want endurance, more like 20 reps. And if you want just kind of general look good, somewhere between 8 and 12 is probably about right. So that's what we need to teach people. But what we do is, the doctor says this, you need to exercise more. And then he leaves. The nurse practitioner says, you need to exercise more. And then they leave. No one ever teaches patients how to actually do it. So maybe you could make millions of dollars teaching patients how to actually do it online. Now, when it comes to losing the weight, what are the 2 really important things? Reduce calories, number 1. And exercise, number 2. Now, what kind of exercise would be best?
Weight training.
Weight training. Why?
Because you're using the muscles.
Walking uses muscles. Running uses muscles.
It's really heavily using.
Okay. When we lose weight, when we reduce calories, we can lose weight from 2 places, right? Mm-hmm. What can we lose? Okay, tissue weight. You can lose fat and you can lose muscle. Is losing muscle going to help our insulin resistance? No. In fact, it might make it worse, right? So that would not be very desirable. So we have to give our bodies a reason to hold on to that muscle. And what is that reason?
Weight.
That's the weight training. So the weight training's job is not necessarily to make you in a more caloric deficit. The weight training's job is to induce your body to keep the muscle that it has. And when you're untrained, you can actually gain a little muscle while you're in that process. The other thing that we need to think about is protein. What is muscle primarily made of? Protein. So when you're trying to lose weight, you might need to increase your protein intake as well. And when I say might, you really should. So, on the diet side, what are the 2 main things we want to do? Tell our patients to do. Decrease your calories.
And exercise.
Increase your protein. Now, this is where people who go with ketogenic and paleo type diets have it easy. Because how do you do that kind of diet? You can eat whatever you want as long as it's not carby. You can eat. So people who go on those diets tend to eat more meat and less cookies. That's pretty good. The problem is you can do those diets really poorly. So if the way that you do keto or paleo is by eating lean meat, it's eating meat and lots of vegetables, great, because that's going to accomplish those 2 items. But if you do them by eating paleo treats, some of those paleo brownies have more calories than regular brownies, right? So you got to be more careful with that. Okay, so we're probably going a little bit too long in this diet stuff, but hey, whatever, you ask questions. But I will tell you that my blood pressure went from slightly high to optimal. My blood sugar went from almost pre-diabetic down to not at all. My triglycerides, which we'll talk about in a few minutes, went from way high down to back to normal. And my HDL, which is the good cholesterol, it's supposed to be high, went from way low back to normal. So everything that you'd want to see for someone who's improving their health happened by making those two simple changes. Eat less, track your calories, eat adequate protein, do weight workouts. Did I ever run at any time during that process?
You tried it out.
No. I'd previously run and realized that it was evil. Yeah. Yeah, I stopped running when I was 22.
Then why did you do the Spartan?
That's not running. I walked it. We walked the Spartan. Yeah, speaking of the Spartan race, the next year's dates are out and our team is up. So if you're interested, you can go ahead and sign up for Team PBA. Although, actually, as students, you guys can get the student discount. So if you want to do it without getting the student discount, you're probably better off waiting till Thanksgiving. There's often coupon codes over Thanksgiving.
Can you do like 2 of them at the same time?
Sure, why not? What 2 are you going to do?
Oh, I don't know. What are you looking at me for?
Because she said, see, there you go to you.
Don't bring me into it because I have no idea.
Okay. So back to our story. What do we want our patients to do? Reduce the calories. Exercise. What kind of exercise is more important?
Weight training.
Weight training. Now, aerobic or cardiovascular exercise does have a place by helping them to lose weight better and helps with cardiovascular conditioning. But when it comes to insulin resistance, your weight or resistance training is probably going to be a bit more important. Also will have the effect of maintaining your muscle mass while the patient is losing weight. So those would be the primary lifestyle changes that we want to see happen. And then we can have a number of things that will help blood sugar that we'll talk about as far as drugs go. All right, now the last thing we're going to talk about before we move on to the actual drugs that we use for diabetes is something called metabolic syndrome. So metabolic syndrome is, now, first of all, what do we mean by a syndrome? What is a syndrome? I got nothing.
The cause?
It's a collection of symptoms or signs. So metabolic syndrome is a collection of signs and symptoms that tend to go along with insulin resistance. Patients who have metabolic syndrome are much, much more likely to go on to prediabetes and then diabetes itself. So metabolic syndrome is 3 out of the 5 of these following things. The first one is an elevated waist. So for men, greater than 40. For women, greater than 35. Those are in inches, in case you're wondering. Second is elevated blood pressure. The third is elevated glucose, prediabetes. That's fasting glucose. The fourth is elevated triglycerides and low HDL.
This was you.
That was me.
No, he just said it. It's true. I didn't mean it in a mean way.
I know.
All right. And I'm missing the fifth one. What's the fifth
Sorry, I
one?
didn't mean it.
The FPG.
I already have that. That's the prediabetes.
HDLs.
Or is it, are these on the same line or are they separate?
They were
Oh, if you separate them, it's bad.
separate. Yeah, that's fine. They were separated.
Oh, yeah. So low HDL. I like to put them together for some reason. So, yeah, so I had 1, 2, 3. I was close to this one. And then when I lost the weight and gained the muscle, guess what happened?
It all
It all went away. Now, what happens if I decide, you know what? I'm done with all this stuff. I'm just going to eat whatever I want again. I'll probably go back. So it's cured in the sense that it doesn't exist anymore, but it's only cured insofar as a person maintains the lifestyle. And that is one of the most important things that we have to get across to patients, is that it's not enough to lose weight. You have to change your lifestyle. For how long? Forever. For the rest of your life. So here's another reason why something like P90X or Insanity is not optimal. How many have ever done one of those programs? How do you feel the very first day mid-workout? Terrible. How do you feel the next day? Even worse. Can't get out of bed, can't go upstairs, can't sit down on the toilet. If you're in your mid-40s or early 50s and you're trying to do that, can you even get through the first workout?
No.
Nope. But if we take you into the gym and we say, here, take these easy weights and put them up over your head. Oh, okay, I can do that. All right, 5 times. That was really great. Okay, now let's try slightly heavier. Okay, yeah, it's a little bit harder. Okay, yeah, that was a little bit hard. Okay, let's just stop there. We'll come back in 2 days, see how you feel. And the person leaves and they go, I don't feel like I even did anything. I feel good. And they come back and they're like, yeah, well, it's a little bit, a little sore, but it's fine. It's no big deal. Okay, that's great. And you do it again with them. How do they feel?
Good.
Good. Okay. So sometimes we have this idea that if it doesn't hurt, it didn't work. And that is just a lie. It's a lie of Satan. It's a lie designed to make it so that you'll never go past the first workout. I feel so virtuous. I hurt myself today. Yeah, it's like you're the 9 Inch Nails. I hurt myself. No, that's Johnny Cash's version. I hurt myself today. You don't know that song? Yeah, anyway. So 9 Inch Nails has a song called Hurt. And Johnny Cash did a version of it before he died. So his version blows away their version. But many of us look at exercise as a punitive thing that we do to punish ourselves for being bad in eating things. Especially those who tend towards the exercise bulimia spectrum of things. But the exercise is not a punishment for the way we've eaten. The exercise is a component to help us be strong so that it improves our insulin resistance. And has the side effect of making you look better and feel better and less likely to be disabled in your old age. So you want it to be easy, especially at first, because when it's easy and enjoyable, guess what people do?
They go back.
They go back, right? Does that make sense? Okay, so metabolic syndrome, 3 out of these things is considered metabolic syndrome, which puts you at risk for insulin resistance and the eventual development of type 2 diabetes.
You only have to have 3 of them?
Yes, only 3. If you have all 5, well, I guess that makes you even more metabolic syndrome-y.
So would like Orange Theory and like hair workouts not be good for somebody?
Not an early person. So if you look at exercise on a spectrum, on the one extreme side, you have strength training where you're like lifting, say, 3 to 4 reps. And then on the far side of that, you've got low intensity, steady state. So like maybe jogging or running, or jogging or walking. And then, as you shift from walking to running, you're going a little bit more that direction, but not a lot. And if you do HIIT, you're a lot more that direction. And so there's different adaptations that happen to your muscles along that spectrum. So there's a lot more similarity between HIIT and weight training than there is between walking and HIIT training. But in terms of muscle maintenance, you're best off with the strength training. HIIT has a lot of good things going for it, but it wouldn't be considered easy, and it certainly wouldn't be the first thing you'd start someone out on if they're sedentary and have not been doing exercise previously. Is that a helpful answer?
Yeah, I just want to sweat a lot.
Say again?
I to sweat a lot.
Yeah. Yeah, I mean, and the thing is, if you like it, you should do whatever exercise you like. Because if you like it, you're going to do it. So if but in the grand scheme of things, if you had to choose, I'm going to run or I'm going to lift weights, most people would be better off, I think, by choosing the lifting weights. Unfortunately, our culture, that's not what we do. We go to running or insanitying or whatever it is. But anyway, we spent far too much time on that. So, any questions about metabolic syndrome? All right, let's talk about drugs. Oh, and I didn't mention, but I should. We used to call a type 2 diabetes adult onset. Why don't we call it adult onset anymore?
Because children can get it too.
Because kids can get it too. And in children, primarily teenagers, the driving factor is obesity. So you may not know this, but there's an epidemic of childhood obesity in the United States. And the main thing driving that is parents. Wait a minute, you mean it's not food commercials? But don't parents love their children? Yeah. So, as it turns out, loving someone doesn't just mean giving them everything they ask for. Sometimes loving them means making some decisions that they will not like. And in our house, we don't drink soda every day. Turns out to be a very unpopular rule with some kids. So,
Busted.
You also said a lot.
Yeah, you do.
today's message brought to you by Coke Zero.
In our house, the kids don't drink soda every day.
Yeah. So, when I was a kid, we did not get to drink Coke every day. Part of my particular problem was I didn't drink Coke Zero because it didn't exist back then. You know what did exist? Diet Coke. And you know what Diet Coke is? Disgusting. Sugared soda is one of the big problems with weight. People who drink it on a regular basis are almost always overweight. Not all of them, but almost always. Now, I'm not talking about like you go out to eat once a week, once a month, and you have soda when you have pizza or something. I'm talking about like people who drink it every day because they tend to drink it many times a day. How many calories in one can of regular Coke? 150. It's 100 calories per cup. So, or for every 8 ounces, it's 100 calories. Now, when you go to 7-Eleven and you get a big gulp, by the way, if you go to a restaurant, Burger King, McDonald's, whatever, and you get the medium-sized drink, how big is a medium-sized drink nowadays? When I was your age, a medium drink was 22 ounces. Nowadays, a medium drink is 32 ounces. So that's 4 cups or 4 8-ounce servings of soda. So how many calories are in a 32? 400. Now, if you go to a place where you get free refills, you get your 32 ounce and you fill it up, and then you drink it and you get another refill. How many calories have you had with your lunch?
800.
800 calories. If you're trying to eat 2,000 calories a day, you can see where the problem is, right? So, partly why I now drink Coke Zero. I know, it's not Coke, but hey. Maybe. You should, except the water doesn't help your throat when you have to lecture 6 hours in a row. Lemonade, calories. Coffee, disgusting. Crystal Light.
Coffee's disgusting. Coffee's oh my gosh.
All right. So for those of you who think that this stuff will kill you, what you should do is you should go to the European Union's website. They actually have a recommendation on this stuff. As it turns out, aspartame is associated with the development of cancer in certain rodents, but not others. But if you look at the amount of aspartame they gave them, you would need to drink, I think it's something like 30 cans a day, every day, for the rest of your life to get the amount of aspartame that they are injecting into these little rats. So you're probably okay. Anyway, back to our story. Let's talk about drugs, shall we? Insulin. So when we give insulin, there's several different kinds of insulin we can give. The first one is regular insulin. Now, regular insulin is basically the insulin that your body produces. Sometimes it's called natural insulin. When your body produces insulin from your pancreas, your blood levels tend to look something like this. What do the bumps represent?
Spikes.
A meal. When you eat food, your pancreas releases more, and that's you get these bumps. So you have kind of like a baseline or a basal rate of release, and then you have boluses for meals, right? Now, the problem is when you take regular, normal insulin out of your body and then inject it as a drug, it doesn't look like that. It looks more like this. So it takes a while before it works, takes longer, and then it lasts a lot longer. So it takes about 30 minutes to an hour before it really starts working, and then it lasts for about 4 hours. As a result, if you have a patient who's going to eat a meal, when would you give them their insulin?
Like 2 hours.
30 minutes before a meal.
30 minutes before a meal. Now, what's the problem with doing that?
It's gonna
They
run.
might not eat.
What happens if they don't eat their meal in 30 minutes?
Then they can't get their insulin.
But how would you know? Mistakes happen in the hospital all the time. Food tray doesn't get delivered on time. Food tray gets delivered early. Patient has to go down for a procedure earlier than expected, but they already got their insulin. So there's a lot of stuff that can happen. And then it also lasts longer than regular insulin. So there's a chance that they can become hypoglycemic toward the end as well. So regular insulin isn't necessarily the best insulin. So what we did, we being the smart people of the world who do biotechnology, and they modified the normal insulin molecule to become what we call rapid-acting insulin. And there's two rapid actings. Those are called Lispro and Aspart. Now, there's two main brands of insulin in the world, Humulin brand and Novolin brand. So, one of these is called Humalog, and the other is called Novolog. So, which one is which?
Humalog is Lispro.
Are you sure?
Yeah. And Novolog is
So, the two logs are rapid acting. Rapid acting. So the rapid actings look much more like a normal insulin spike. I hate the word spike. Do you see a spike there? It's a nice round hump. But the Novolog and Humalog look much more like a normal physiological increase in insulin. They usually start 10 to 15 minutes after injection. So you're going to administer them with the first bite of a meal. You don't give it until the patient starts eating. That's a lot safer because if the food tray comes late, well, you haven't given them insulin already. If the food tray comes earlier than expected, well, you just give them the insulin then. So it's more convenient and safer for the patient. It also doesn't last as long, so the risk of hypoglycemia later is not as strong either. Hypoglycemia, does they say hyper? Yes, hypoglycemia risk after a meal isn't quite as strong. Now, all insulins can cause hypoglycemia as an adverse effect. So you always want to make sure that a patient eats after getting their insulin. The amount of short-acting insulin should be calibrated to the amount of carbohydrate that a person is eating. The amount of rapid-acting insulin should be calibrated to the estimated amount of carbohydrate that a person is eating. If a person eats a higher carbohydrate meal, they should generally be getting a higher dose of Novolog or Humalog. Does that make sense? Okay. All right. So, regular and rapid together are short-acting insulins. Everything else we're going to talk about is a longer-acting insulin. So, the next kind that we call are intermediate. There's several different kinds, but really there's only one that's currently being used, and that one is called NPH. You do not need to know what NPH stands for. It's complicated.
So this works. Those work faster than this works slower?
Yes, works slower than normal. So when you give this, it's going to look like this. So it's this really long, big, round hump. Okay. So the onset is about 4 hours. And it lasts about 8 hours. Now, in the old days...
In addition to the 4 hours it takes to work?
Yes. So, I mean, it's not going to really work until about 4 hours. And
then you get 4 more hours.
Yeah. Yeah. So in the old days, what we would do is we would combine NPH and regular into the same shot, same syringe, and we'd inject them at once. And so what would happen is the regular would cover you for breakfast, and then the NPH would cover you for lunch. Now, what's the downside of that strategy? You have to eat lunch by a certain time or you'll start to become hypoglycemic. The other downside is there's not a lot of flexibility in your lunch because you've already dosed yourself. You can't over or under eat. Well, you shouldn't anyway. So this required a certain amount of planning and rigidity to your lifestyle if you're going to really do it well. Nowadays, what we typically do is we use the next kind, which is a long basal insulin. And the main brand there is, well, the main kind is Glargine, which is also known as Lantus. And there's another one, I'm forgetting it, but you can look it up in your book. So the idea with Lantus is that when you give it, you get a baseline level across the entire day. It's flat the whole day long. So what we typically do nowadays is we would give the patient 1 shot of Lantus in the morning, and that's going to give them this baseline rate all day long. And then we're going to give them Lispro or Aspart with their meals. Now the downside of this approach is how many shots does it take? Assuming you eat 3 times a day. It takes 4 shots because you can't mix Lantus with anything else. So it takes 4 shots instead of 2 because you've got to give them 4 shots of insulin. When you were combining your NPH with either regular or a rapid, you only needed 2 shots a day. What's more convenient, 2 shots or 4 shots?
2 shots.
2. So is it more expensive to get 2 shots or 2 shots or 4 shots?
4 shots.
It's more expensive to get 4 shots because you got 4 syringes, all that. Which one has better glucose control? Yeah. The 4 shots has by far better glucose control. But there's a downside to glucose control. What's the downside to glucose control? The more tightly you control glucose, the more at risk you are for hypoglycemia. So there is an increased risk of hypoglycemia with the 4 shots a day. By the way, the name for the old way is conventional insulin therapy. And the name for the newer one is, I forget the name. I forget what it's called.
So the
Aggressive, I think, is what.
What, the older one being NPH?
The NPH plus the rapid or short. Yeah. And they also have pre-mixed versions of those.
wait, what do you mean are short?
Regular insulin is short acting, not rapid.
Oh.
So they actually have pre-mixed versions of NPH plus either normal or one of the rapid actings. So when you combine it with regular, it's usually, 70-30. And when you do it with a rapid, it's usually 75-25. So the nice thing about getting the premix is that you don't have to do any mixing. So it's better for patients who aren't that good at math. Just draw it up and give it. The downside of a premix solution is that you don't have a lot of flexibility. You only have one ratio, it's already mixed, that's all you got. So with conventional therapy, it's a little bit cheaper. It's only 2 shots a day. That's nicer in terms of you don't have to stick yourself twice a day, but you've got to be more rigid in your lifestyle. Also, typically you don't control the blood sugar as well. With the newer therapy, you got to have 4 shots a day, but much better glucose control, but an increased risk of hypoglycemia. You also have more flexibility in terms of meal timing, and you can eat different sized meals because you're calculating the amount you need at the time that you eat it.
And the new way it's a little longer, the basal with a rapid, right?
Mm-hmm. And that brings us to our final method of delivering insulin, which is an insulin pump. So insulin pumps can use almost any type of insulin, but nowadays I believe it's mostly rapid insulin. And the way that they work is they give a baseline level of insulin throughout the day. And then when you eat a meal, you administer a bolus based on the amount of carbohydrate that you're expecting to eat at that meal. So it delivers a basal rate, so a baseline rate of insulin all day long, kind of like your pancreas does normally.
Okay.
And then when you eat a meal, you give yourself a bolus amount of insulin based on the amount of carbohydrate that you're about to eat. Estimated usually, unless you bring a little food scale with you. Did you bring a food scale with you?
No, we use calories a lot.
Yeah. So when we give insulin, the vast majority of the time we're going to be giving insulin subcutaneously. Now, what do we know about the effects of insulin on fat?
It can either increase or decrease it.
It causes fat cells to take in more triglycerides and store them. So it's going to have an effect on the local fat cells in that region. As a result, what we want to do is we want to rotate insulin sites. You don't want to give it in the same spot every day. Now with an insulin pump, you usually keep it in the same spot for 3 to 5 days, and then you're supposed to change spots. But a lot of patients, no, I don't want to do that. It's just not convenient. I like to keep it in the same spot. But doing that over time will result in changes to the fat cells in that area and can also lead to a crystallization that can actually inhibit the ability to absorb the drug. So sometimes if the insulin pump stops working, the reason why is that they haven't been rotating the site. So you need to get them to rotate the site. And nowadays, we have the ultimate in control, which is a continuous blood monitoring. So like instead of sticking your finger and checking your blood glucose every now and then, is a little probe that goes into your skin and it continuously monitors your blood, your blood glucose levels, and then that talks to the pump, which in turn makes adjustments while you're just hanging around and doing stuff. Yes. So it's kind of like a little pancreatic feedback mechanism. I've got an article I can send you about it. One of my friends from college, he's a computer programmer, and his daughter has diabetes, and he talks about how horrid these companies are in terms of their software is just terrible. So a group of parents who are technically savvy, tried to make their own thing, and like the companies wouldn't let them with patents and everything. It's like ridiculously stupid.
The sweets at home got hacked.
Yeah.
Electronic ones, they had to recall a bunch of them.
Yeah.
So tech savvy.
So, yeah. All right. Any questions about insulin itself? What's the number one adverse effect? Hypoglycemia. What can make hypoglycemia worse? Interactions. What? Alcohol. Yeah, alcohol has a tendency to lower blood sugar, but many alcoholics actually have high blood sugar because they drink things that have carbohydrates in them. So,
Straight alcohol?
Yeah, so like liquor will have a tendency to lower blood sugar, but wine and beer have a tendency to raise blood sugar. So it just depends. It also depends whether the person eats and drinks, or they drink instead of eating, which is also another issue. Another thing that can interact with it is the amount of exercise. So if a person exercises much more than usual, let's say that they go on a vacation, and they go on a tour where they're walking 10,000 steps, and ordinarily in a regular day they only get 2,000 steps. That will dramatically lower the amount of insulin that they need that particular day. Yeah, so exercise lowers the amount of insulin needed. And that can occur in both type 1 and type 2 diabetes. Oh, and you can have an overlap of type 1 and type 2. You can have type 1 diabetes and still be insulin resistant. I know, right? And then, quick review from Pathopharm 1. What are the signs and symptoms of hypoglycemia? What are the early signs of hypoglycemia? That's late.
Lightheaded.
Okay, lightheaded, shaky, irritable. Okay, so the hangry symptoms. So a tremor, headache, irritability, and diaphoresis. Those are caused by what response? Sympathetic response. So if a patient is taking a drug that inhibits sympathetic response, what might happen? Nothing. They might miss those early signs and symptoms. So what kinds of patients, diabetic patients, should be careful about taking what kind of drug? Beta blockers. Now, beta blockers come in two flavors. What are they? Selective and non-selective. So which one should a patient?
Selective.
They can take a selective, but they have to be careful about what? They have to be careful about monitoring their blood sugar because they might miss those early signs and symptoms. And then the later signs and symptoms would be confusion, disorientation, coma, death. Now, you guys in this class learn how important it is to have really good blood glucose control, and how the better control you have, the fewer microvascular complications you're going to have. And so you're under the impression that we always try and control a patient's blood sugar super tight. And then you go into the hospital and their blood sugar is like 140 and they're like, yeah, whatever, it's fine. Why is that?
Because they're not dead.
Okay. In the hospital, we're dealing primarily with acute illnesses. And the microvascular complications of diabetes are 30 years away. That physician dealing with that acute illness isn't really caring that much about super tight blood glucose control. As long as they're under like 180, 150, we're cool, man. That's what he's thinking in his head. So don't expect super tight blood glucose control in the hospital. The other thing is that patients are under a lot of stress. And what happens when we're under a lot of stress? Blood sugar has a tendency to go up because of the sympathetic response and the cortisol response. On top of that, a lot of patients in the hospital are on corticosteroids. What's one of the adverse effects of corticosteroids? Hyperglycemia, increased blood sugar. So as a result of that, you shouldn't necessarily expect all of your patients to have normal blood sugar in the hospital, even though that's the place where you have the potential to most tightly control blood sugar. Does that make sense? If a person's blood sugar is 140, is it going to cause any problems today? No. If a person's blood sugar is 40, could that cause a problem today? Yeah, it can kill them right now, right? So from a doctor's perspective, it's much better to have you slightly high than slightly low. Does that make in the hospital? Mm-hmm. So that's just one thing to think about. The other thing, as long as we're talking about insulin, is that insulin is given to both type 1 and type 2 diabetic patients, but there's an enormous difference in the dose. A person with type 1 diabetes is probably going to be getting, somewhere between 50 to 150 units per dose. If they're getting, intensive, that's the word. It's conventional versus intensive therapy. See, I'm not as old as I thought. Don't have Alzheimer's yet. So, with conventional therapy, usually what you would do is you would get 2/3 of your units in the morning, because you're going to eat breakfast and lunch, and then you'd get 1/3 of your units at night. Does that make sense? So the morning dose would be double the evening dose. So let's say that they're going to get 150 units throughout the entire day. How much would they get in the morning? 100. And how much at night? 50. So that would be fairly typical for someone with type 1 diabetes. With type 2 diabetes, because their pancreas is still producing insulin, just not enough insulin, you're going to have much, much smaller doses of insulin. So you might be having insulin doses as small as 2 units or as high as maybe 15 to 20. But you're not typically going to have super high insulin in type 2 diabetes. Does that make sense? All right. Now, just one last thing. In type 2 diabetes, remember we said the insulin levels go up and then eventually they start coming back down. There comes a moment in time where essentially the body isn't producing any insulin at all, and that's called pancreatic failure. And at that point, a type 2 diabetic is treated as though they're a type 1 diabetic. In type 2 diabetes, the pancreas tries to keep up with insulin demand, but eventually it can't. And it kind of like hangs out, but eventually its amount of insulin production will actually go down. And so there comes a point where it's producing so little insulin that it might as well be none. And then you treat that type 2 diabetic person, they call it pancreatic failure, you treat them like they're a type 1 diabetic with the added complication of insulin resistance. So I know of a patient, he's about 350 pounds, and he's had diabetes for like 40 years. And he, even though he's type 2 diabetes, takes, I think, 300 units a day of insulin because, he's so big and needs so much, and he's got pancreatic failure. So even though that, you typically would see a person, if a type 1 diabetic takes this much insulin, and then a type 2 diabetic usually takes that much insulin, if at all, there's, on the other end of the spectrum, a really obese person with type 2 diabetes, pancreatic failure, who's taking this much insulin. So you can't just go by what the diagnosis is. It's got to be individualized. And there's room for error because if you ever have a patient and you're like, I'm not sure this is the right dose, ask them, how much insulin do you normally get? And they'll tell you. So sometimes you're like, I'm not sure I should be giving this much insulin to this kind of patient. And it turns out, no, that's how much they normally get. And then other times it's like, yeah, you really shouldn't be giving them that much. Does that make sense? Okay. All right. Any other questions about insulin therapy? Okay, let's talk about the other things now. All right. These used to be called oral hypoglycemics. So what does that imply? It lowers blood sugar, and you give them by mouth. However, some of these things are no longer oral, some of them are injection. So they're just other hypoglycemics. And the vast majority of them are used only for type 2 diabetes, but some of them can also be used in type 1. So we'll talk about those when we get there. And then the other thing to remember is that you can have both type 1 and type 2 in the same patient. So sometimes you'll see a patient who's being treated both ways. So the first one, we're going to do them more or less in the order in which they were invented or discovered. So the oldest ones are sulfonylureas. Oh, sorry, one last thing before we get started. The two major approaches to treating type 2 diabetes are either one, increase the amount of insulin that the pancreas is producing. So basically make the pancreas work harder. And the second is to decrease insulin resistance. So as we go through each of these types, I'll say which one it is. Does that make sense? Okay, so sulfonylureas were the oldest ones that we had. They have a sulfa component, which means that a patient who's allergic to sulfa is at risk for what? Stevens-Johnson syndrome. The way that they work is by increasing the amount of insulin that is being produced by the pancreas. Yeah. So because they increase insulin levels, what do you think the number one adverse effect is? Risk for hypoglycemia. They also have a tendency to be associated with weight gain. Now, what does weight gain do to your insulin resistance? It makes it worse. So here's a drug that successfully treats a symptom. It makes your blood sugar go down, but it makes the condition that caused the insulin resistance in the first place worse over time. So as a result, even though sulfonylureas work well short term, they're associated with an increased risk for pancreatic failure in the long term. They used to be the first drugs that we used, what we call first-line therapy, because they were the first ones we had and we were the most familiar with them. But nowadays, they are no longer considered first-line therapy.
You said they increase the amount of insulin that the pancreas makes?
Yes. Yes. Sulfonylureas are divided into two groups based on when they were invented and the characteristics. So first generation are older. Pretty much no one uses them anymore because you had to take them several times a day. The newer ones are long-acting. You only have to take them 1 to 2 times a day, and they have fewer adverse effects. So pretty much everyone uses these nowadays. And there's 3 drugs you need to know. Those are glimepiride, known as Amaryl, glipizide, known as Glucotrol, and glyburide, which I can't remember what it's known as. Sure. So I guess I'll write them backwards. Glyburide, can't remember its brand name. Glipizide, what? I can't understand what you're saying.
Several? Oh, I think several of them.
Glipizide, which is Glucotrol, and glimepiride, which is Amaryl. These are all second generation. You don't need to know any first generation because pretty much no one uses them anymore. And if they do, I mean, it's so rare that there's no point in keeping them in your head. These you'll see on quite a regular basis. But again, the use of sulfonylureas is beginning to decrease somewhat.
And it's given orally, right?
And it's given orally. So until the invention of the next drug, these were the most commonly prescribed. But the next drug class, called biguanide, changed all that. There's 2 drugs in the biguanide class, but one of them is no longer used because it can cause liver failure. So the only one that's left nowadays is metformin. Now, if you look on internet forums, you would think that metformin is the worst possible drug in the entire world, but in fact, it's actually one of the best drugs in the entire world. So metformin works in multiple ways. One of the things it does is it decreases the amount of blood sugar being secreted by the liver. So remember, your liver is a storage place for glucose in the form of glycogen, and when you need it, your liver will release it by doing glycogenolysis. And sympathetic response causes glycogenolysis, and so does, what's the word? Drawing a blank. Getting old. Don't do it. The hormone produced by the alpha cells of your pancreas. Glucagon, there you go. So, in response to both glucagon and sympathetic response, you're going to get glycogenolysis, increasing the amount of blood sugar that you have from the liver. And metformin inhibits that from happening. So it directly prevents blood sugar from going up. But metformin also has a number of other effects which result in a decrease in insulin resistance. So it increases insulin sensitivity. And there's also some actions that it has in the gut. So because of that, because of the gut actions, it's associated with GI upset and possible diarrhea, but also decreased appetite and weight loss. So the adverse effect of decreased appetite and weight loss, would that be helpful for a patient with diabetes? Yes. Why, yes. So in fact, metformin does 3 things that are really helpful for a diabetic patient. It decreases blood sugar control now by reducing the amount of sugar from the liver. It causes an increase in insulin sensitivity, and it also helps the patient to lose weight, which in turn will cause a long-term increase in insulin sensitivity. So in many ways, it's considered a wonder drug. And the best part is the risk of hypoglycemia by itself is very, very low. So it doesn't really cause hypoglycemia by itself.
Why does everyone not like it?
Because of the GI side effects. There's people in the world who believe that all drugs are evil and bad, and all herbs are wonderful and good. I'm not one of these people. Now, some herbs can be helpful and good, but drugs are often much better than the herb form. But whatever. The important thing is metformin is the #1 first drug that people are started on most of the time. It is now the first-line therapy. I remember working with the doctor. He's like, sometimes you start low and go slow, and sometimes you hit them and hit them hard. And with metformin, you hit them and hit them hard. The one thing to be careful about with the hit them and hit them hard is that the GI adverse effects will be worse when you hit them and hit them hard. So you do want to ramp up the dose a little bit slowly. You don't want to start them off at a max dose. Metformin can come in immediate release and delayed release. So if you do the delayed release, you only need to take 1 dose a day.
For delayed?
Yeah, for the long acting. So metformin is probably the #1 drug used for type 2 diabetic patients in the world today. And it's by far the most important one for you to remember. Now, some things about metformin that are concerning. It generally should not be given to patients with renal failure or heart failure or liver failure. However, in recent times, the recommendations have been loosened. So now you can give it to patients with mild renal failure, and heart failure.
So from your podcast before it's changed that?
Yeah. So that recommendation came out, I want to say about 2 years ago, but I could be wrong because I lost track of time.
So then where would the lactic acidosis toxicity come in? Or is that
Yeah.
something anymore?
Right. That part is the liver failure.
Okay.
Yeah. So we still don't give it in liver failure.
Okay.
It does have the potential to cause acute liver failure, although it is fairly rare. All right, next we have what are known as the meglitinides. Sorry, the TZDs. The TZDs are also known as glitazones because they all end in glitazone. Now, there's 3 drugs, but one of them is no longer available because it could cause liver failure. So the 2 that are left are rosiglitazone and pioglitazone. Rosiglitazone was put on the market, then taken off the market, and then put on the market again. So I guess it was safe, unsafe, safe again. So these 2 drugs work by reducing insulin resistance. There is a potential for liver damage, so you want to make sure that the patient's liver functions are being monitored. And they have the potential to increase fluid retention. Now, in and of itself, that's not a bad thing. But if you have a patient who's at risk for heart failure, it can kick them into heart failure.
Increase what?
Fluid retention.
Only heart failure?
Only heart failure. So if you have a patient who's at risk for heart failure, it can kick them into heart failure. So you need to be a little bit careful with patients at risk for heart failure. It's not that they can't have it, but they need to be monitored for signs and symptoms of heart failure. Now, we haven't talked about heart failure in this course yet, so I'm not going to make you answer those kinds of questions on this test. But you need to be aware that it could happen. Yeah, what the heck? Maybe we will give you that kind of question. So, a person in heart failure, what's the number 1 symptom of heart failure? Shortness of breath. Number 2, weight gain from fluid retention. So, fluid retention can cause weight gain, pedal edema, and what other kind of edema?
Pulmonary.
Pulmonary edema. How would you know a person has pulmonary edema? Crackles. So, a person who is at risk for heart failure, who's getting one of these drugs, TZD, glitazone, what should you do for that patient?
You should listen to their lungs.
Listen to their lungs
Weigh them every day.
and weigh them every day. Okay. That's pretty simple.
You said what 2 types of edema? You said peripheral?
Peripheral and pulmonary.
Yeah.
So this was in the slides too, like the animal models. Do we even know?
You don't need to know the animal models.
I didn't think so.
Yeah, so what an animal model means is that it might happen in humans and it might not. We don't know.
That's what I figured.
Yeah, because sometimes animal models are incredibly predictive of humans and sometimes they are not. So as an example, if you give a rat less food than usual, it'll lose weight. If you give it more food than usual, it will gain weight, but only up to a point, and then it stops. But if you give a human more food than usual, it will not stop. So, yeah. If only we had rat genetics in that regard. So anyway, those are your TZDs. Anyway, next we have what are known as meglitinides. Now, meglitinides are similar to sulfonylureas. The way that they work is by increasing the amount of insulin that is produced by the pancreas. The big difference, though, is they only increase insulin production for about 2 to 4 hours. So the primary way that you give these drugs is for patients who have normal blood sugar control most of the time, but they're having postprandial increased blood sugar. What does that mean? 2 hours after the meal, their blood sugar is higher than it should be. But otherwise, they're pretty normal. That's the person who should get imoglutinide. 2 drug names. One is repaglinide, and the other one is similar. The brand names are Prandin and Starlix. So the one you need to remember is repaglinide.
We don't need to know.
Not for your test. For life, it'd be helpful to remember, but for the test, no. Okay, so that is meglitinides, which I have no idea if I spelled that right. I can't even read my own writing. The next one are alpha glucosidase inhibitors. Now, what the heck is alpha glucosidase? It's an enzyme that breaks down glucosides. Yeah, glucoside. So, most of the sugars that we eat are not simple sugars. They are complex sugars, and they have to be broken down. So the way that you break them down is with enzymes, including glucosidase. So by inhibiting glucosidase, you reduce the rate at which those complex sugars are broken down into smaller sugars. Now, can your body absorb smaller complex sugars? No. Your body can't absorb lactose, it can't absorb sucrose, it can't absorb anything bigger than a monosaccharide. So by giving them a drug that inhibits that, you slow down the absorption of carbohydrates. And that in turn will reduce the rate at which glucose comes into your bloodstream, reducing the amount of blood sugar at any given time. Now, in the United States, these drugs are not very common. The main adverse effect is gas, flatulence. And in America, we do not like our flatulence. These drugs are much more common in Asia, where there's a very high carbohydrate, high rice diet. But in the United States, you typically are not going to see these drugs given as much. Now, one thing, they don't cause hypoglycemia by themselves. But if a patient is on, say, this drug and this drug, a sulfonylurea and an alpha-glucosidase inhibitor at the same time, and that patient gets hypoglycemia, what do you have to think about? You got to give them a glucose tablet and not something with sugar in it, regular sugar in it. Why?
Because then it will delay the breakdown of the sugars if you give them like orange juice or something and they need it now.
Yeah, if you give them Coke or if you give them orange juice, there's a high amount of sucrose in both of those items. As a result, they're not going to be able to absorb it, and it will not help them with their blood glucose as much. So patients who are taking an alpha-glucosidase inhibitor should have glucose tablets available. As far as drug names go, the main one, well, there's 2 of them, but the one you need to know is acarbose. Have you ever noticed how sometimes there's like 1 drug and then other times there's like 15 drugs? Mm-hmm. So sometimes what happens there is that if a drug is super successful, there'll be like a whole bunch of similar drugs that come about also. Where if a drug is like, it's okay, then there's not as many that come along that try and imitate it. So anyway. This is the end of the older drugs. At this point, we're going to go to newer drugs. So the first newer drug is amylin analogs. So amylin is a substance that is produced by your beta cells. Now, if there's beta cells in your pancreas, what does it imply there should also be? Alpha cells. So here we've got an alpha cell. Here we've got a beta cell. Where are they living? In the pancreas. And what do we know beta cells produce? They produce insulin. And the insulin goes off and it works where? It's supposed to be a U. Everywhere in the body. That's the definition of a hormone. It gets released into the bloodstream, and from there, it can affect potentially any tissue. But it also produces another thing that affects nearby cells. That's called paracrine hormone, in case you're wondering. So paracrine substances affect nearby cells. And that substance is called amylin. Amylin tells alpha cells, hey, don't produce glucagon. What is the purpose of glucagon? You got nothing. To raise the level of glucose. So glucagon raises glucose in several ways. One of the ways is by having your liver secrete glucose. How does it secrete glucose? By breaking down glycogen, and in more severe cases, by gluconeogenesis. It also tells your brain, hey, we need some glucose. Why don't you eat something? So it increases hunger. Now, when your blood sugar goes up, you produce insulin to lower blood sugar, but you also produce amylin to suppress the amount of glucagon. Because if there's lots of blood sugar around, do we need to be releasing a hormone that increases blood sugar? No. What happens in type 1 diabetes? We destroy the beta cells, so we destroy the amylin producing cell also. So, amylin can be used not only for type 2 diabetes, it can also be used for type 1 diabetes.
So in type 1 diabetes, alpha cells are still doing their thing?
In type 1 diabetes, the alpha cells are still producing glucagon.
Okay.
And so in type 2 diabetes, sometimes the problem isn't so much that there's not enough insulin, is that you've got insulin and glucagon both being produced at the same time, sending conflicting signals, which in turn causes like a vicious cycle of let's keep eating. So by giving amylin, you suppress appetite, and you also suppress blood sugar production by the liver. Amylin analogs are given by injection. All right, next we have glucagon. Sorry, go ahead. Someone say something? Okay. All right. So next we have something called incretin, which is also known as GLP-1, which stands for glucagon-like protein 1. So there's a protein in your blood, found in your blood anyway, that is called GLP-1. That's based on its structure. It looks kind of like glucagon. But it also has another name, which is incretin. And this goes back to some research that was done a long time ago, where they would feed someone a certain amount of glucose and measure their blood sugar and insulin response. And then they would do the same thing, give them the same amount of glucose, but instead of giving it to them orally, they would inject it into their vein. And what they found is that patients who had it go through their abdominal tract had a much higher insulin response than usual. Or not usual, but higher insulin response than when they gave it to them IV. So they said, there must be some sort of factor that is increasing the response of insulin. And so that factor that we thought might be there, we named incretin. Pretty cool, huh? So, we didn't know if incretin existed, but we thought there might be something that existed that did that thing. And that thing got called incretin. And then later on, decades later, we realized that that incretin is actually this glucagon-like protein 1, GLP-1. So what is the relationship of GLP-1 to incretin? They're the same thing. And it's secreted by your intestines, by your small intestines. When you eat a meal and your intestines are full, they secrete incretin. And incretin does a couple things. One is it tells the pancreas, hey, we could use some insulin right about now. It also sends a signal to your brain saying, hey, brain, there's food in your gut. You don't need to eat more, okay? So it suppresses appetite. And incretin also enhances the sensitivity of your cells to insulin. So it works in 3 different ways. Do you remember what they are? Heck no.
The increases sensitivity to what?
So the first thing is it causes your beta cells to secrete more insulin. It tells your brain we don't need to eat. So feeling of satiety of I feel like I've eaten. I'm good now. And it also increases sensitivity of your cells to insulin. So 3 mechanisms of action. Now, there's 2 types of drugs that can affect incretin. The first one is called incretin mimetics. What do you think that does? It mimics incretin. So it's an artificial incretin or incretin receptor agonist. So the first one that was invented, the one that we're going to learn, is called exenatide. Or is it exenatide? Exenatide. And the brand name is Byetta. So these drugs work by enhancing or activating incretin receptors. They're given by injection. Any questions?
So now we need to measure our names for each of these pests.
The next one is there's an enzyme that breaks down incretin. And that enzyme's name is dipeptidyl peptidase 4. You can call it DPP4. How's that? So, DPP4 inhibitors inhibits will inhibit the breakdown of glucagon. And these all end in gliptin.
Why do they
Glucagon-like protein 1, GLP-1, also known as incretin. So let me rephrase that. DPP4 inhibitors inhibit the breakdown of incretin, making it work better. So these drugs all end in gliptin. So the first one discovered was sitagliptin. That's the one you guys are going to have to know on your test. But any gliptin is a DPP4 inhibitor.
Which one do we need to know for it?
Sitagliptin. So these drugs are not as effective as the mimetics, but you'll still see them used, and sometimes you'll even see them used together.
What's the name of that?
Sitagliptin.
Take a shot and darts over it.
Sitagliptin. Sitagliptin.
It's not with a C, it's with an S.
S-I-T, sit.
I spelled it with
C-I-T is not sit.
Sometimes it can be.
C-I-T is nothing. So, sitagliptin. And then we have our newest drug class, which is SGLT2 inhibitors. Now, what happens to blood sugar in your kidney?
Taken in and stored like
We have enzymes that are responsible for pulling it back in, right? Transport mechanisms. Okay, so part of those transport mechanisms is a substance known as SGLT2. When you inhibit SGLT2, the glucose is allowed to stay in your urine. And then what do?
Pee it out.
You pee it out. So this is one of the newer treatments for type 2 diabetes. Now, and remember, in type 1 diabetes, glucose in your urine is bad, right? That means your blood sugar is above 180. Okay. So with SGLT2 inhibitors, you can have glucose in your urine even at normal level, relatively low levels of blood sugar. So like 150, 180. Sorry, not 180. 150, 140. Now, what do you think could happen to a patient whose urine suddenly has glucose in it? Is there ordinarily glucose in your urine? Now there is. What is urine supposed to be?
The color yellow, like the clear, clear yellow.
Yeah.
Purple.
Sterile. What does that mean? How many bacteria ordinarily live in your urine?
0.
If you have bacteria in your urine, what do we call that? A UTI. So patients who now have sugar in their urine, it's an energy source for bacteria, more at risk for UTIs. They're also at risk for osmotic diuresis, which could increase the amount of urine they produce, which in turn means they might need more fluids than usual. Now, because we're treating type 2 diabetes, the risk that that's polyuria from like way overshooting is probably fairly low. The other nice adverse effect of these drugs is that the patient will likely lose body weight. Body weight. Because they're peeing out energy. So now they're at a caloric deficit all of a sudden. If you give these drugs to patients who don't know they're getting these drugs, they typically lose somewhere about 10 pounds. But then the weight loss stops. So something in a person's has this ability to somehow sense, I'm losing weight. I don't want to lose weight. Let me eat a little bit more food. There, you balance things out. But weight loss is one of the adverse effects, although in the case of a type 2 diabetic patient, it's not necessarily that adverse. Most of the time, anyway. All right. Any questions about SGLT2 inhibitors?
What's the
Drug name?
Is that a class?
Oh, yeah, drug names. Say again?
That's a class.
That's the class. It's canagliflozin.
Right.
What's the mechanism of action for it?
It inhibits this particular molecule, which in turn allows urine or glucose to spill into your urine. So canagliflozin, which the brand name is Invokana. No, we will never take a break. All right. Any questions about canagliflozin? Yeah, to me it sounds like a floozy. But anyway, yeah, I know. We're going to take a break in 1 second here.
Start a revolution.
Simlin. Yeah, so the amylin analog is Simlin.
How do you spell it? For which one?
Symlin.
Thank you. Simlin.
Simlin.
I know, but it corrected it to Simlin.
Oh, yeah, whatever. Okay, on that note, any other questions about diabetes?